Okay. Good morning, Prof. Good morning, my consultants, and Dr. Deshi Batlomi from a registrar and surgery department, Federal Medical Center, Abuja. I'll be presenting the pathology and management of acute pancreatitis. This presentation was supervised by Dr. Adigi Jain, consultant general surgeon. So I will be using this outline. Okay, so by way of definition, acute pancreatitis is the inflammation of the pancreatic parenchyma characterized by edema, ductal changes, and necrosis when severe. Acute pancreatitis can reoccur. So, as a statement of surgical importance, management of acute pancreatitis presents a challenge to both the surgeons and the physician, largely because of diagnostic dilemma, and also sometimes this patient will present when it is severe or advanced. So the role of surgery in the management of acute pancreatitis cannot be overemphasized, most especially in the management of local complications. The incidence of acute pancreatitis, there are paucity of that data in our area, but some few studies done, one conducted by a BT Ugu et al. Of the Department of Surgery, Jos University Teaching Hospital, found that the incidence of acute pancreatitis is 1.4 to 13,775 per year. And this figure is quite low compared to that in the Western countries. Acute pancreatitis accounts for about 3% of all cases of abdominal pain among patients in the UK. The hospital admission rate for acute pancreatitis is 7.9 per year per 1,000 population in the UK. In a study conducted to determine the global, regional, and national burden of pancreatitis in 195 countries and territories during the period of 1999 to 2017, a systematic analysis of the global burden of the disease was done and published by the BMC Medicine. On the 10th of December 2020, the global rate of prevalence of cases of acute pancreatitis had increased from 3 million to 6 million in 2017. The age standardized prevalence was 6.67 in 1990 and 76.2 in 2017 per 100,000 of the population, which shows an increase of 13.3% from 1990 to 2017. Although the worldwide annual incidence may range from 5 to 50 per 100,000, the disease may occur at any age, with a peak in young men and in older women. So by way of anatomy, the pancreas is an endocrine, is a gland with both endocrine and exocrine function. It has a duct, the main pancreatic duct, which join with the common bile duct and open at the major duodenal papilla. There's also in some individuals an accessory duct of Sartorini, which opens at the drains the Onsnet process and the upper part of the lower part of the head and drains into the minor duodenal papilla. In some cases, usually the main pancreatic duct is formed by the duct of the dorsal duct and that of the ventral duct, and this form the common or main pancreatic duct that join the common bile duct. However, in some individuals, the duct of the ventral, the duct of the dorsal pancreatic duct can open separately into the minor duodenal papilla, and it drains the bulk of the pancreas, including the tail, body, neck, and head, and can open into the that's the minor duodenal papilla, and this is quite small, and when such occur, that is called pancreatic divisum, and there will be slow emptying of its content and lead to stasis and increased risk of acute pancreatitis. So by way of physiology, the pancreas has an endocrine and exocrine function. The endocrine function has the following cells: alpha cells that secrete glucagon, beta cells secrete insulin, delta cells somatostatin, and pancreatic peptide cells that secrete pancreatic polypeptide. The exocrine pancreas secrete its contents through the duct, unlike the endocrine that secrete contents into the blood directly. So we have the enterokinesis, which secrete the trypsinogen that is later converted into trypsin, the amylase and lipase, which are involved in carbohydrate and fat metabolism. So the etiology of acute pancreatitis as follows. The most common are gallstones and alcohol consumption. Other causes could include post-endoscopic retrograde choledochoric pancreatography, abdominal trauma. It could result from biliary, upper gastrointestinal, cardiothoracic surgeries, ampullary tumor, drugs, hyperthyroidism, hypercalcemia, hypertriglyceridemia, pancreas divisum, sphincter of Oddi dysfunction, autoimmune pancreatitis, hereditary pancreatitis, viral infections, malnutrition, scorpion's bite, and idiopathy. So the pathogenesis of alcohol pancreatitis. So many theories have been promulgated about how alcoholism can cause pancreatitis. This includes sphincter of Oddi spasm, increased secretions, and then cytokines-mediated autodigestive injury, necroinflammation, and cell death, ethanol-induced ductal permeability, and increased protein content in pancreatic joints, and decreased bicarbonate and trypsin inhibitors concentration. The increased protein can actually cause stasis and ductal obstruction, formation of protein plugs, which can contribute to the obstructive element, as I mentioned. The gallstone pancreatitis, there are so many hypotheses too. One is the common channel hypothesis, as the pancreas and the gallbladder drain into the same fuse and open at the same duodenal papilla, major duodenal papilla, so there could be reflux of bile into the pancreas and cause pancreatitis. The transient incompetence hypothesis is seen when there is passage of a stone through the common pancreatic duct. It's been shown that some contents, duodenal content, can trickle in immediately, but however, this theory has been controversial, as there is no increased incidence of pancreatitis post-sphincterotomy. Duct obstruction with ductal hypertension have been also isolated in patients with idiopathic pancreatitis. So following the above injuries, the pancreatitis is thought to be as a result of pre-activation of the zymogenes, that's the trypsinogen that is activated to trypsin, and this causes the autodigestion of the pancreas. So any injuries that occurs at the acinar cells and impair secretion of the zymogen granules or damage the ductal system can cause pancreatitis. So once the cellular injury has been initiated, the inflammatory process can lead to edema, hemorrhage, and eventual necrosis. As inflammatory mediators are released into the circulation, systemic complications can arise, such as hemodynamic instability, bacteremia, acute respiratory distress syndrome, and pleural effusion. Gastrointestinal hemorrhages, renal failure, and disseminated intravascular convolution can also ensue. Lipases too have been shown to cause fat necrosis, and elastase destroy blood vessels, and this can lead to hemorrhagic pancreatitis. Pathophysiology. Following the acute, there are varying degrees of severity, and the determinant of which are multifactorial. The initial insult is at the level of the acinar cell, but the severity depends on the event that occurs after the acinar cell injury. So this could be local event, which include some cytokines, and then the generation of free radicals and macrophages release, which can cause local and systemic inflammation. These mediators can cause increase in vascular permeability, leading to hemorrhage, edema, microthrombi with subsequent failure of pancreatic microcirculation, hypoperfusion, and necrosis. In the systemic event, this is the most important aspect of the pathophysiology of acute pancreatitis, as it determines the severity of the disease as well. And the mechanism by which it occurs is the activation of NF-κB activation and also the trypsin activation, though these are two independent pathways, because in experimental study with trypsin knocked out mice, it's been shown that this process is still uninhibited and cause massive stimulation of cytokines release. The drivers of the systemic event are poorly understood, but are thought to be due to pro-inflammatory cytokines and sepsis. So this is just a diagram to show the systemic manifestation of the capillary, the gut barrier, and the alveolar causing acute respiratory distress syndrome, acute tubular necrosis, and sepsis and shock. Management of acute pancreatitis usually will include the clinical presentation, history and examination, investigation, treatment, complications and treatment of some of the complications, and outcome and follow-up. So the cardinal symptom of acute pancreatitis is pain, which characteristically develop quickly, reaching maximum intensity within minutes. It persists for hours or even days. The pain is usually first experienced in the epigastrium, but may be localized to either the upper quadrant or felt diffusely through the abdomen. The pain radiates to the back and relieved by sitting or leaning forward. There could be nausea with repeated vomiting and retching. Patients could have hiccups from irritation of the diaphragm. The appearance may be that of a patient who is well. It could just be a mild illness. Some of them will not present. Or at the other extreme, some patient can present severely ill with profound shock, toxicity, and confusion. Patient could be tachycardic, tachypneic, and hypotensive. Temperature could be normal, subnormal, high, or swinging pyrexia in case patient develop pancreatic ulcer or there's coexisting cholangitis. Patient could also be jaundice if there is cholangitis. Bleeding into the facial planes can produce a bluish discoloration of the flanks, which is called gray tonal sign and umbilicus colon sign. There could be subcutaneous fat necrosis, which could present as a red tender nodules on the skin. This is an image showing the colon and gray tonal sign. The clinical presentation on the abdomen may be distended. There could be ascites, guarding, and rigidity. Pleural effusion and pulmonary edema and pneumonitis can occur as part of the respiratory complications. Patient could be confused. There could be signs of metabolic derangement with hypoxemia. To investigate this patient, we can divide it into hematological, biochemical, and radiological. However, when investigating a patient with acute pancreatitis, we should be able to, investigation should answer the following question: that is the diagnosis of acute pancreatitis based on clinical suspicion correct? How severe is the attack and what is the etiology? These are very important. So now to make the diagnosis with the history, an elevation in serum amylase of 3 times the upper limit of normal, or lipase 3 times the upper limit of normal, is almost diagnostic in a patient with characteristic sign. So further investigation will just aid in the in determining severity and also further confirm the diagnosis. However, amylase rise early and drops rapidly during the attack, and so it does not correlate well with the severity of the disease. So lipase is more specific. Serum calcium should be assayed. Lactate dehydrogenase, patient can have hypocalcemia. So lactate dehydrogenase will be elevated. Patient could have hyperglycemia. On liver function test, patient could have deranged liver function test if DIC has set in. And then also there could be features of acute kidney injury. Full blood count could also confirm if there is superimposed infection with sepsis, and also a clotting profile can be done. Radiologically, the following investigation can be done, though they are not specific to diagnosing pancreatitis. On chest X-ray erect view, the following signs can be seen, though they are non-specific, as I said. So the patient could have pleural effusion or diffuse alveolar interstitial shadowing if in the very severe form of acute respiratory distress syndrome. Patient could also have linear focal atelectasis on the lung basis, elevated diaphragm on the left if patient have developed a pseudocyst or pulmonary edema. Abdominal X-ray too is non-diagnostic. However, some of these non-specific signs can be seen: generalized or local ileus, which is seen as sentinel loop. There's a colored cut-off sign, which is inflammation around the splenic flexure. Renal halo sign, which is the inflammation in the pancreas extending to the pararenal fats, and then we could see calcified gallstone or pancreatic calcification too on X-ray. The abdominal ultrasound does not establish the diagnosis of acute pancreatitis, but should always be done in patient within 24 hours. This is very important because if it is due to gallstone as the cause, and then that could also help and help in the management, as patient could benefit from early intervention. To rule out acute cholecystitis as a differential diagnosis too, which is a close differential of acute pancreatitis, to also determine whether the common bile duct is dilated or not. Other investigations that can be done could include MRI, MRCP, endoscopic ultrasound scan, and ERCP. Usually MRCP and endoscopic ultrasound scan can be done in preparation to intervention, most especially in patients with gallstone pancreatitis, and also to determine whether the patient will benefit from endoscopic retrograde cholangiopancreatography, which is reserved where patient will need both diagnostic and intervention. So, the indications for a CT with intravenous contrast will include when there is diagnostic uncertainty, or in patients with severe pancreatitis to distinguish interstitial from necrotizing pancreatitis, and also in patients with organ failure or signs of sepsis or progressive clinical deterioration. Also, when a localized complication is suspected, such as fluid collection, pseudocyst, or pseudoaneurysm, or even necrosis. So, this is the Betalta CT scoring system. A is normal pancreas, B enlargement of the pancreas, inflammatory changes in the pancreas, C ill-defined single peripancreatic fluid collection, 2 or more poorly defined peripancreatic fluid collection. Okay, this on my right and on my left hand side is a CT scan showing a pancreatic pseudocyst, shown by the white arrows, while on the right-hand side is an MRI of a T2 weighted MRI, where the cyst appears white because it's fluid, and then you can see the black arrows are pointing at the area of pancreatic necrosis in the pancreas. So, assessing the severity of the patient with pancreatitis is also very important, because this will also help the clinician to prepare on this patient management and the level of care. So, the following severity classification has been used. The one is the revised Atlanta classification, which classifies acute pancreatitis into mild, moderate, and severe. So in mild, there's no organ failure and no local or systemic complication. In moderate, there is organ failure that resolves within 48 hours. That's what we call the transient organ failure. During the resuscitation, the organ failure is the function of the organ is restored, and then or when there is a local or systemic complication without persistent organ failure, which is considered moderate, and then the severe form are persistent organ failure, single or multiple organ failure. Then the determinant-based classification does look at this into 4 mild, moderate, severe, and critical, which you can always look at them. Then there's also a modified determinant-based classification too. So the ransom classification, which is very important, this is for pancreatitis not due to gallstone disease. So the following parameters are looked at: the age of the patient, greater than 55, considered bad prognostic, WBC greater than 16 times 10 raised to 9 per liter, blood glucose greater than 11 millimoles per liter, lactate dehydrogenase greater than 350 units per liter, and AST greater than 250 units per liter on admission. Then within 24 hours, 48 hours of resuscitation, the hematocrit fall of greater than 10% is considered poor prognostic. Blood urinary nitrogen rise of greater than 5 milligram per dl, despite fluid resuscitation, arterial oxygen saturation of less than 8 kilopascal, or serum calcium less than 8 milligram per dl, or less than 2.0 millimoles per liter, and depth deficit of greater than 4 millimoles per liter, and fluid resuscitation of greater than 6 liters. So usually prognostic fine. Then this is another for pancreatitis due to gallstone. Can take a look at it later. So the Glasgow score 2 is also very important in assessing acute pancreatitis. So this is a sequential organ failure assessment score in acute pancreatitis. So usually we can use it to know which organ are really failing. So multiple organ dysfunction failure can be defined as any score of 2 in any of these, or in any 2 of these organs is considered a score of 2. In at least 2 of these organs is considered multiple organ dysfunction. So management of mild acute pancreatitis is usually conservative. We resuscitate the patient with intravenous fluid, analgesics, and a brief period of NPO in nauseated patients. However, if patients are fasted for too long, they can develop ileus and also feed intolerance. However, if patients are also in case of severe pancreatitis, if they are fed too early, the patient can also develop non-occlusive mesenteric ischemia. Frequent but non-invasive observation is recommended here. CT is not necessary unless there are evidence of deterioration, as earlier stated. So in severe acute pancreatitis, patients should be admitted into a high dependency unit or intensive care unit. Analgesia, preferably paracetamol, but can use the analgesic ladder, can use meperidine, and even NSAID has been shown to be useful as well, but no morphine, as it can cause sphincter of ODD spasm and further exacerbate pancreatitis. Aggressive fluid resuscitation too is recommended. Some supplemental oxygen should be given. Invasive monitoring of vital signs using central venous pressure, urine output, and blood gases. Frequent monitoring of hematological and biochemical parameters is very important. Nasogastric drainage should be used only in the initial phase, but the goal is to start early enteral feeding. Antibiotics, if there is cholangitis or systemic sepsis, but prophylactic antibiotics is not usually recommended. It is very debatable, so many authorities said it's not recommended. CT can be essential if organ failure, clinical deterioration of sign of sepsis develop. ERCP within 72 hours in severe.
Hello, discuss ìwé wa.
The early management of severe acute.
Utilize it just has Oni Atola nìkan ló rán ní.
Supportive therapy of organ failure if it develops, like use of support and hemofiltration.
Maximize
Nutritional support if required. We can consider enteral feeding, which is the preferred standard. The surgery in acute pancreatitis one is to
We are having background noise from Dr. Abdulmajid. Please, can you help us with background noise?
So the role of a surgeon in acute pancreatitis is to include in the management of gallstone pancreatitis, which is very important because of the need for cholecystectomy, and management of the local complication, and also in the diagnosis of acute pancreatitis, where we can use the ERCP and other intervention. So the local complication of acute pancreatitis include peripancreatic fluid collection, sterile pancreatic necrosis, infected pancreatic necrosis, pancreatic ulcer, pancreatic ascites, pseudosis, pleural effusion, pseudoaneurysm, portal or splenic vein thrombosis. So just to discuss a few of these local complications, pancreatic necrosis refers to a diffuse or focal area of non-viable parenchyma. This can be identified by absence of parenchyma enhancement on CT with intravenous contrast. Usually start as an acute pancreatic collection, which subsequently developed into wall of necrosis within 4 weeks. They are usually sterile, but most times they get infected, and in sterile collection should not be drained. But however, if there's evidence of sepsis, one should consider whether the collection is infected or not. So, and this can be done usually by percutaneous aspiration of the content through a CT or ultrasound guidance. And if it is infected, then internal drainage, that's endoscopic or external drainage using a percutaneous under image guidance can be done. Pancreatic necrosectomy can also be considered if sepsis worsened despite the conservative measures, and this can be done either with an open or laparoscopic approaches. Thorough debridement of the dead tissues with vigorous irrigation and suction is done, and also a feeding jejunostomy can be done during this procedure. If gallstone is a precipitant, then cholecystectomy can also be done. But once necrosectomy has been completed, just like any other debridement, there could be further necrotic tissues that could be formed. And there are several ways of dealing with this, which could include the close continuous lavage, where a drain can be left in situ and then it should be flushed almost daily. While in closed drainage, there is a use of a Penrose drain, which can be removed after 7th day to drain any collection. While in open packing, the tummy is packed and then a second look is done to check for healthy granulation tissue, or a further debridement can be considered. While in closure and relaparotomy can also be considered after 48 to 72 hours. None of this method is shown to be superior. However, the last two, open packing and closure and relaparotomy, have been shown to make more logical sense. Pancreatic abscess, this is a circumscribed intra-abdominal collection of pus, usually in proximity to the pancreas. It may be an acute necrotic collection or a wall of necrosis that has become infected. The principles of management and diagnosis are as outlined in the infected pancreatic necrosis discussed earlier, and antibiotics should be given in this case. In pancreatic pseudosis, is a collection of amylase-rich fluid enclosed in a well-defined wall of fibrous or granulation tissue. Occasionally, a cystic neoplasm can be confused with a pseudosis, but this can be differentiated by endoscopic ultrasound and also fluid analysis for carcinoembryonic antigen, a level greater than 400 nanogram per dl. We consider highly suspicious of a mucinous carcinoma. Amylase can be elevated in. Amylase is usually elevated in.
Hello, Mr. Genesis. Hello.
Amylase
Yes,
is
you
usually
continue.
elevated. Amylase is usually elevated in a pseudocyst. However, this is not diagnostic, as there are also mucinous carcinomas that are communicating with the ductal system could also show an elevated amylase. On cytology, pseudocysts would show inflammatory cells, presence of inflammatory cells, while on cytology of a malignancy, we could see malignant cells. So pseudocysts usually resolve spontaneously, but complications can develop, which we will look at subsequently. The pseudocysts that are thick wall or large, greater than 6 centimeters, or have lasted for a long time, greater than 12 weeks, or have arisen in the context of chronic pancreatitis, are unlikely to resolve. However, this should not be managed operatively, as there are indications to operative management. These are some of the complications that could arise from a pseudocyst. If they are infected, it could lead to abscess or systemic sepsis. If they rupture into the gut, it could lead to gastrointestinal bleeding or internal fistula, or into the peritoneum, could lead to peritonitis. If they are enlarged, they can cause a mass effect, which could cause obstructive jaundice if they are compressing the biliary tree, or intestinal obstruction if they are compressing the bowel. Also, from this enlargement, they could cause stretching of the capsule and also pressure on its supporting structures, and that could lead to pain. They could also erode into vessels, causing hemorrhage into the cyst or hemoperitoneum. Indications for operative intervention in pancreatic pseudocysts could include when they are symptomatic, or when they develop complication as listed above, or a distinction has to be made between a pseudocyst and a tumor. And there are three main approaches. A percutaneous drainage. Percutaneous drainage can be done with percutaneous image guidance through and putting and draining into the exterior, but this is not usually advocated, because if the cyst is communicating with a ductal system, that could lead to a pancreatico-cutaneous fistula, or if it is a malignancy has not really been ruled out, that could lead to upstaging of the malignancy. Other percutaneous drainage could be percutaneous transgastric cyst gastrostomy, where under image guidance, a pigtail stents can be placed into the with one end in the stomach and the other end in the cyst, so that it continues to drain. Endoscopic approaches could include use of endoscope. Sometimes, if this pseudocyst is communicating to a ductal system, also at endoscopy, a stent can also be put at the ampulla of vita to facilitate drainage. Also, surgical intervention can be done, which could be open or laparoscopic, and this could be through cyst gastrostomy or cyst jejunostomy. Systemic complication of acute pancreatitis includes cardiovascular system like shock, arrhythmias, acute respiratory distress syndrome, pneumonia, and atelectasis, renal failure, hematological complications like decimated intravascular complication, metabolic like hypocalcemia, hyperglycemia, hyperlipidemia. Also, intestinal complications like ileus and bleeding. Neurological could range from visual disturbance, irritability, confusion, and encephalopathy. Hepatobiliary complications include jaundice, stricture, and other complications that could arise as subcutaneous fat necrosis and arthralgia. The outcome and follow-up of patients with acute pancreatitis, the overall mortality of acute pancreatitis has remained at 10 to 15% over the past 20 years. There is a clear responsibility before the patient is discharged to determine the etiology of the attack of pancreatitis, which is very important. Failure to remove the predisposing factor could lead to a second attack of pancreatitis, which could be fatal. A proportion of patients in the idiopathic group who suffers repeated attacks may prove to have biliary microlithiasis, which can be identified only by bile sampling at ERCP or by endoscopic ultrasound scan. If in a patient who has a gallstone pancreatitis, the gallbladder and gallstone should be removed as soon as the patient is fit. to undergo surgery, usually preferably before discharge from the hospital. Current trends in the management of acute pancreatitis include the use of platelet activating growth factors to ameliorate the severity of acute pancreatitis. The interleukin antagonists or cytokines antagonists have been shown to reduce the systemic inflammatory response syndrome that comes with acute pancreatitis and has shown to improve the systemic manifestation of patients with acute pancreatitis. In conclusion, acute pancreatitis is a self-limited disease in which most cases are mild. The incidence is underestimated as most of them are misdiagnosed. Gallstone and alcohol remain the leading causes of acute pancreatitis. Most patients will need just supportive care, and surgery is indicated in complicated cases and in patients with gallstone disease. Thank you for listening. These are my references.
Yeah, Dr. Deshi, thank you for your presentation. It looks well researched, but I will reserve my comments towards the end of contributions. So the floor is open. It's a mixed audience, so I don't know most of the people here, but please, you identify yourself. We are going to start with the resident first, then subsequently the consultants, if we have senior registrars, consultants, and then our teachers, the professors can also make their own contributions. So starting from the residents, medical officers, house officers, anyone at that level can make his or her own contribution. Thank you. Please feel free to make your comment, ask your questions.
Good evening, consultants. Good evening, professors, consultants, and senior registrars. Thank you very much, Dr. Deshi, for your presentation. My name is Dr. Usman. Hello?
Yeah, we can hear you.
Okay, my name is Dr. Usman. I just have one question to ask and a contribution to make. My contribution is there's a classification system for acute pancreatitis. It's called the Trapner etiological classification. You just gave us etiology. You listed etiologies into like you stated stuff like alcohol, biliary stones, obstruction, and other things, infection, and other things. There's a classification system that tries to classify the etiological factors for acute pancreatitis into major and others. It's called the Trapner classification system. So for the major, we have the alcohol and then the biliary tract obstruction. It could be stones in the biliary tract. It could be bile reflux. It could be pancreatic duct obstruction. So biliary tract obstruction are the ones it's classified under major. It accounts for about 50% of the cause of acute pancreatitis. Then followed by alcohol. Alcohol contributes about 25% of for the cause of acute pancreatitis. Then the others may include trauma, infection, drugs, and iatrogenic causes like the ERCP that you made mention of. My question is, what are the normal preventive mechanisms that the body tries to use to prevent a patient or to prevent an individual from having acute pancreatitis? Thank you very much.
So,
Thank you for the question and contribution.
Note the question.
Yes, sir.
More comments and questions from the residents.
Let me ask Dr. Usman, are you trying to find out whether the body, what the body does to prevent a severe, the worsening of pancreatitis, or that the pancreatitis actually, because the process, once it started, it has started. So what, can you frame your question the way you can answer? Otherwise, it will be prophecy to say the body has stopped pancreatitis from taking place. What do you want to use that question?
Okay, thank you very much, sir. Sir, while trying to, read through acute pancreatitis, I saw that there's a normal defense, there's a normal mechanism that the body tries to use to prevent a normal person from having acute pancreatitis, such as the enzymes that are produced by the pancreas are released in an inactive form. And then the enzymes, the pancreatic duct is usually impermeable to these enzymes, so they don't get in contact with the acinar cells or the parenchyma of the pancreas itself. And also that these enzymes are also membrane bound, so they are not in contact with the parenchyma of the pancreas.
Good. I think it's better you made the point yourself. You understand? Because
yes, sir.
Yeah, it's he tried to mention something maybe not as detailed as you have done, but this is the contribution you are making, and let's leave it at that point.
All right, thank you very much.
Thank you, Prof, for that clarification. I appreciate that, sir. And Dr. Usman, thank you also for the comment and for that clarification. So I think we are through with the residents. For senior registrars now, senior registrars in the house.
Hand is up.
Hello.
You now see, but Shiladoe wants to speak.
Okay. Okay, go ahead and speak.
Thank you very much, the presenters. Good evening, everybody. Thank you for the elaborate presentation. I just have some few comments. In the pathophysiology of acute pancreatitis, I think we now talk about the co-localization of some organelles within the acinar cells. And that's the co-localization of the zymogen granules and the lysozymes, which contains the cathepsin B and the trypsinogen. So when there is any when there is any trauma or anything that could incite acute pancreatitis, these two organelles do combine, and there is the cathepsin B usually activates the trypsinogen, which forms the trypsin, and trypsin now activate other enzymes like the elastase and the rest of them, which causes the damage. And once they cause damage, there is acute inflammatory response with the release of interleukin 1 and interleukin 1, interleukin interleukin 6, and the rest of them, the TNF alpha and beta, which further causes more inflammatory response, and the cascade continues like that. This is one of the ways where, which one of the explanations given to the pathophysiology of acute pancreatitis. Then in making diagnosis, there is this international consensus that if a patient has two of any of the following presentations, when they have abdominal pain, which is consistent with acute pancreatitis, and being consistent means that maybe it is acute in onset, it is epigastric pain, which radiates to the back, and usually worsened on lying down. This is abdominal pain that is consistent with acute pancreatitis. That is one. Patients with like you have rightly mentioned, patients with the amylase level or lactose level, which is about 3 times the upper limit of normal. And if the third factor is if there is any characteristics on imaging that is suggestive of acute pancreatitis. So any two of these three is enough to make a diagnosis of acute pancreatitis. You mentioned about the use of narcotics and NSAID being the preferred Yes, there have been mentioned they mentioned about the use of narcotics, but I think most textbooks said it does not affect the outcome of acute pancreatitis. So narcotics can still be used. It is written in some of the textbooks I've come across. And I think those are the few comments I have about. There are so many other things, but these are the few ones I can remember for now. Thank you very much for the presentation again.
Yeah, okay. Thank you, Doc, for your comments. Maybe I will still come back to the use of narcotics. I know, yeah, he mentioned we can use some of the narcotics, but morphine, he was specific with respect to morphine. I don't know whether you have whether the literature you came across mentioned morphine, and morphine can
Yes,
be used.
yes, ma. It was actually morphine specifically that was mentioned that can be used. Yeah, they say it can cause the construction of the symptom of OD, but they say the studies have shown that it does not affect the outcome of acute pancreatitis. That's what I came across, ma.
Okay, it's all right. Thank you for that clarification.
Thank you, ma.
So, more comments and questions from the senior registrars.
Hello, sir. I don't know. Hello.
Yeah, Eze, we can hear you.
Thank you so much. Thank you, Dr. Dechi, for your presentation. Thank you, my teachers, for allowing me to speak. I heard you mention Collins and the Donald sign, but I don't know whether I heard you mention Van Zandt sign, which is a very specific sign that can be used to make a diagnosis in this condition, which is when the patient sits up and bends forward, the pain is relieved, and then there is a specific sign. So, and also the grading or the staging of pancreatitis. You mentioned the Ransom criteria, but there are other criteria which are also there, even though they are very, sometimes they may not be used technically, very cumbersome signs. The Apache 2 criteria, they have also been used to stage the signs and be able to make a diagnosis. And then again, the biological markers, reason here you mentioned the use of C-reactive protein, which is also, though not specific, but can also be used. And this arises from the fact that interleukin 6, when it begins to rise, can also stimulate the release of C-reactive protein, and then can be used in addition to other genetic markers, chemokines, and others. Then you said a lot of things about the treatment, including the surgical application. You know, when there are complications like abscess, pseudocyst, and other complications, which are very, very important for surgeons, and is a very common question in our exam, which all of us need to know: the surgical application in management of pancreatitis. So it's a very important, very well researched and well delivered presentation. And I thank you, Dr. Deshi, for this very good presentation. Thank you.
Yeah, thank you, Dr.
sir.
Eze, yeah, for your comments. I appreciate that. So, more comments and contributions, questions, senior registrars, we still have them in the house. Okay, I think we can step out to our chiefs now, the consultants. Please feel free once you have something to say. I don't know whether I have challenge seeing any hand that is raised up, but if you are moved to speak, please feel free to speak.
That was a very good word you used there. If somebody is moved in the spirit. There's no hand that is up, but I think Obo he's moved his system a bit up. Maybe he would like to speak.
Thank you, sir.
Okay, Dr.
Thank you
Boka,
very
go
much.
ahead.
Thank you, Dr. Gosi, for your presentation. It's a good presentation, and I think you have a good control of it. But usually we know that acute pancreatitis could be acute or chronic, and which also determines the management of this disease. So you'd have told us about how it becomes what is a chronic or pancreatitis. In managing pancreatic pathology or pancreatitis, there is a stage where you may need ICU management in the patient when it is very severe. We should also know that managing pancreatitis, initially, in mild cases, antibiotics is really not needed. And antibiotics should not also be given in case you want to say you are given as a prophylaxis. It's only when it is actually established and is needed, antibiotics is usually given. And then there is something you say that I want you to verify that. Say when it will become severe and advanced. I really don't understand what you mean by that. Can you elaborate on that? Thank you.
Yeah, Dr. Bo, thank you for we appreciate your comments. Thank you so much. Sure. So, Deshi, was it a slip of tongue? Severe and advanced. What do you really mean? Or what do you meant by that?
Yeah, sorry about that. I meant to say severe.
Okay.
Yes.
I think I agree with you. Because I know we didn't come across anything like advanced pancreatitis, acute pancreatitis. Okay. So more comments and questions from the consultants. Okay.
Vash is around?
And most time he's around. He's also part of the, I don't know, the moderator. So most time he like making the comments towards the end. I don't know, but if you can make his comments now, we appreciate that. Dr. Bashi, if you can hear us, you can make your comments.
Good evening, Prof.
Good evening, Bash.
Good evening, everyone. Sorry, I was on a transit. That's why I could not comment earlier on.
Okay.
Dr. Deshi, thank you for the very interesting presentation, but I have some observations. You see, when a patient presents with acute pancreatitis, sometimes you might experience or have diagnostic dilemma because they present with acute abdomen that have features of generalized peritonitis in most of cases, except when there is complication and there is clear-cut signs that you will pick that this is an acute pancreatitis or a complication of an acute pancreatitis. There retrospectively, you now know that that recurrent epigastric pain that patient is having is not peptic ulcer disease, it's not any of the differential diagnosis. So what I'm trying to say, you should hammer on the differential diagnosis, one, and how you differentiate acute pancreatitis from those differential diagnoses. So this is very, very important in your presentation. So the common differential diagnosis and how you commonly differentiate those conditions from the presentation of acute pancreatitis. That is one. Secondly, aside the differential diagnosis, your complication almost appeared as a presentation on its own because you went into detail. Because if you look at the topic, it's specific. pathology and management of acute pancreatitis. But the way you go into the in-depth in the management of complication, someone will almost think you are managing pseudocyst or one of the complications of pancreatitis. The reason why I'm saying this is because your presentation is time-bound, okay? Your presentation is time-bound. If you keep on talking without streamlining based on the topic you are being asked to present, you might not be able to finish. And if you are writing essay, you might derail. Okay, that is my second observation. Then my third observation, you see, your pathology, your clinical features should actually be explaining the pathology. If you say a patient has a burning epigastric pain or a sharp epigastric pain that is aggravated by lying supine and relieved by leaning forward, what in the pathology or the pathogenesis of acute pancreatitis causes such? So you see, you should be able to interpret all these signs, all these symptoms based on the pathogenesis so that your presentation will have a link, okay? Dr. Eze asked a question on Van Zandt sign, okay? Tell us about Van Zandt sign and tell us about the pathogenesis. So by and large, it was a very nice presentation, but you have to work on time management and a kind of streamlining your presentation to focus on the topic. Then you now go to town on the those topic, the topic that is being you are asked to present. So thank you very much. But you should tell us more about that Van Zandt sign and why is that so? Why does it happen? Thank you very much.
Yeah, thank you, Dr. Bashir, for your contribution. Especially, yeah, okay. Go ahead, Dr. Deshi.
Okay, Van Zandt sign is a sign that describes the pain of acute pancreatitis, which is usually worst on lying supine, but the patient feels relief when he leans forward. So that leaning forward is the Van Zandt sign. I think the mechanism is that with the patient leaning forward, there's no stretching of the pancreas, which is already inflamed. So that relieves the patient a bit. While lying down, the pancreas, we know it runs in the posterior abdominal wall transversely. So the stretching of the inflamed tissue, I think that's what makes the pain worse.
You know, the pancreas is a retroperitoneal structure. Is that not so?
Yes, sir.
And there are viscera. There is abdominal, there are intestine and other viscera in front of that retroperitoneal structure. Is that clear? So when the patient lies down, what happens? There is compression of that inflamed structure by the viscera that are in front of it. You see in your anatomy, the anterior relations, you have the stomach, the small bowel, and some things, transverse colon. So when you are lying supine, the weight of this viscera is compressing on the pancreas that is inflamed. So they have pain. But when they lean forward, what happens? You displace that viscera anteriorly and the pain is relieved. So this is just an example how you use the pathogenesis to explain the manifestation. It doesn't necessarily have to be a very lengthy presentation, but your ability to see a patient coming up with an acute abdomen and making a diagnosis of acute pancreatitis is very important because this can pose a diagnostic dilemma, especially to a resident. So thank you very much. Well done, Dr. Bish.
Thank you, sir.
Thank you. Yeah, thank you, Chief.
Thank you, Dr. Bashir. So I will quickly make my comments and also present my observation before Prof makes his final comments and will conclude. So Dr. Bashir and the previous speaker, I appreciate your contributions, but some issues have been raised, and thank God we have one of our trainers of trainers here with us, that I want him also, Prof, if you kindly help us also to clarify some of the issues that have been raised, because if a resident is asked, will you use morphine in the management of pancreatitis, either acute or chronic? I don't know what the answer should that resident say yes or no, candidate, as the case may be, during exams, because I think these are maybe new literatures are saying yes, we can use narcotics, but the previous literatures, they will specifically write, don't use morphine. It causes spasm of the sphincter of OD. So can resident, yes, recent ones may be saying, yes, we can use that, but during exams, can we say, okay, resident can, or candidates can actually say that or write that? And what will be the attitude of the examiners towards that? Then with respect to, I agree with you, Dr. Bashir, the issue of diagnostic dilemma, which he mentioned somehow. So I think it can actually be managed by both gastroenterologists and the surgeon. So for me, I actually allowed him to go in depth into the pathology, because I feel that the role of the surgeon in the management of pancreatitis is more with the complications. But it's just like PUD. PUD can be managed by gastroenterologists and also by the general surgeon, but our role is more with the complications. So I also want, if during exam, the question is, what's the role of the surgeon in the management of acute pancreatitis? Should the resident just write on plain pancreatitis, or should he emphasize also on the complications? Then I think the differentials, we have to take that home. We mix that together. Dr. Bashir, thank you for bringing that up. It's very good. We should have mentioned the differentials and how to differentiate that from acute pancreatitis. I think these are the few gray areas I've observed thus far. Because I'm the moderator, I went through this, I can't critique myself, but these things are some of the things that I think that we need further clarification, so that when the take home will be this and that based on this. Thank you so much. I appreciate all your comments, questions, and contributions. Prof, over to you, sir.
Okay, thank you very much. It's always good to have areas that are controversial, because they give us room to conduct research and to learn more and not just stay on one point. We're looking at the classification. Anytime you see diversity, it means that we have not really quite agreed on a particular thing, and some people are looking at it from another side. But be that as it may, the use, I must commend Dr. Deshi. I think he was able to express himself very well. I think he did quite a lot of reading. Looked at the references that he put up here, including one local reference. And I think that shows that he's made good efforts. Some of the references are still a little bit far from what we should see today, but all the same, that was a good effort. So let me say that in discussing, there's really no surgical subject that doesn't have pathology, and that pathology, the only thing is has to be fairly very relevant. And for a presentation like this, I think he did. In fact, there are some issues where his attention was drawn as to practically how we are moved from the cellular level to the molecular level, which he was attempting to mention but didn't quite mention all. But I think like what Bash is saying is that the time allotted, the way he spent the time, seemed to have been emphasizing some areas more than, I think everything about basically the subject he has taken was appropriate. The issue is that you have 30 minutes, or if when essay is 1 hour, for this presentation is 30 minutes, and you should apportion your time to be able to speak on the meat of the thing. let's give an example about the classical presentation of symptoms of acute pancreatitis. He had some trouble bringing that out very clearly. I think he should have brought that so clear. By the way, all the cases of acute pancreatitis that I saw, we did not know it was acute pancreatitis until we actually opened. So let's not give the impression that the thing is something you can just, quickly see a patient and say, oh, this is acute pancreatitis. Can be quite dicey, really, until you just, you have an acute abdomen, and you sort out the rest as you make, of course, you make some differentials. If a man has been on alcohol and is an alcoholic, you can, hazard a guess, but may not be too straightforward. Now, let's talk about the use of narcotics. I'm going to send you an old article. I say old because it is a 2008 article. But it just talks about this same subject we're talking about now. Should you use morphine or should you not? I compare that with metamizole, and there have been some of these. I think we should always realize that the textbook gives some dictum. Amazingly, some story has gone over acute appendicitis, whether you should give anybody analgesics while waiting to operate or not. So the textbook said, no, don't give. But there have also been articles, and when I'm discussing this kind of subject from the point of view of exam, it's good not to be too dogmatic. One person study may have shown that he used, just like this article I'm trying to send to us. Yes, they used morphine, it was all right, but that's not the body of opinion. That is an expression. So to play safe is to say what the standard practice has been, but to also say that this other bit is being tried. You won't run into foul weather. But if you say that the old use of morphine has been abandoned, then you will be entering into a big problem, because you will not be there to bring the journals that have said now that this is what you should use. So I think to play very safe is to draw attention, like he tactically did, about the challenge for use of morphine. It's a very good drug. It will bring controls the pain very quickly. But in some instances, it also produces a re-spasm of the sphincter of Oddi, which will create a bigger problem subsequently. So if you were hoping that I will be able to tell you the A, B, C, D, choose E, that would be a little bit out of place to say for a presentation like this. But I can say very clearly that yes, it has been tried, and the standard text say no, don't use, but a number of individuals have articles to show that yes, you can use it. But I wouldn't want us to take that as a generalized view. Up to this moment, there are many other things that are being used. My other comment, which I thought somebody had already tried to emphasize, is that in a presentation like this, it's good to look at the etiological factors and then to see how this can actually even be prevented. So I expect that when Dashi really dealt with the subject and was coming out of it, he should have also told us one or two things about the preventive measures, especially when he talked about recurrent pancreatitis. By the way, I agree with Bash that perhaps he did too much with the complications. Deal with acute pancreatitis, and then you tell us, yes, there could be sequelae, and these are the sequelae. But to take all the time dealing with the sequelae was also not completely okay for a presentation. But all said and done, no body of information is useless. For me, he has done a fairly good scholarly work, which shows we should actually be happy that he has done this kind of fairly thorough work. But I think that he failed to mention some complications of acute pancreatitis itself, which should be mentioned. So that's the few things I would like to say. The last thing I would like to say to Deshi, and I don't really blame him because I think he hasn't really seen a case of acute pancreatitis. If you have seen, you would appreciate what we're saying. And I think a presentation like this will require you mention a little bit of that. So over to you, Francis. I think you've also coordinated this well. I saw a lot of pictures which Deshi showed. Deshi, you can't finish quoting people's works. So some of those others, you should have just mentioned them without having to show us the full tables. You could just mention this is another classification, but try and come down on what is most popular and you discuss it. That way you would have saved time to deal with some of the questions that were brought up to you subsequently. So that's it. I don't know if I've attempted to answer your question, Francis, but I'm saying that there is a progressive change in the use of analgesics in various acute surgical conditions, which before we say taboo, no, but now they are being considered. But I'm also saying that that consideration does not mean the old teaching is abandoned. It is still there, just that there are now some few exceptions to what people are saying. That's what I would like to say. But yeah, I think he has done well. He has done well.
Thank you so much, Prof. We're always privileged to have you around.
Thank you, Prof.
You always be our teacher. So thank you so much. I appreciate you joining us from your busy schedule and all the rest of it. You still make our time to be part of this. We really appreciate that.
Thanks.
God will continue to strengthen you. So I think I'll hand over to the overall coordinator, Dr. Bashir, so that if he has anything he wants to say, he can now conclude the presentation. Thank you so much.
Thank you, everyone. Thank you, Prof. Thank you very much for your comments, contribution, and guidance. And thank you, Chief Adigije, for your wonderful contribution and time you invested in moderating Dr. Deshi's presentation. And Dr. Deshi, well done. You have been commended by Prof that you went to town and read widely in preparing for the presentation. I will encourage other residents to copy such. The presentation for next week will be fluid and electrolyte management, fluid and electrolyte therapy in a surgical patient. And a resident will be given the topic to present. So all those residents in the forum can go and read wide around this topic so that they can make meaningful contributions. Thank you very much, and thank you all. Good night, all. Thank you, sir.
Thank you all.
Thank you.
Yes. Francis, God bless you.
You too, Prof. Bless you, sir.
Remember us in your kingdom, or if there are good things you brought from the leaf.